So the objective of the work was to assess the prognostic ability or capacity of circulating tumor DNA at the end of therapy in patients who are being treated for diffuse large B-cell lymphoma in the front line. So the problem that we're trying to get around is that PET scans are the current standard of care for response assessment in DLBCL after frontline chemoimmunotherapy. And while they're great, we know that PET scans have limited sensitivity and specificity. And so the question we were trying to answer was whether ctDNA-based MRD tools could improve on that sensitivity and specificity. So our approach was that we studied a real-world cohort of 99 patients with newly diagnosed diffuse large B-cell lymphoma who were diagnosed at our collaborators' site in Samsung Medical Center in South Korea. And these patients all were receiving frontline chemoimmunotherapy. And our goal was to assess the role of circulating tumor DNA MRD both at an interim time point, which means after 3 cycles of treatment, and at the end of therapy after 6 cycles of treatment. And so from those 99 patients, we attempted to collect plasma samples after cycle 3 and at the end of therapy. We then performed ctDNA-based MRD testing at Foresight Diagnostics and correlated that with outcomes in PET responses. And we found that while both PET scans and ctDNA MRD both stratified overall survival, we actually found that circulating tumor DNA better stratified outcomes and at a higher hazard ratio. So patients that had detectable circulating tumor DNA had a higher hazard ratio than patients that had detectable disease on a PET scan. Another major finding from the study was we compared the progression-free survival rates and overall survival rates at 24 months using both PET scans and ctDNA as the predictor. And we found that ctDNA had both a better positive and negative predictive value when measured at the end of therapy relative to PET scans. So when we went back to the cohort and looked only at patients that had discordance between their end of therapy PET scan and their end of therapy ctDNA scan. That means either one is positive and the other is negative. And among patients that were positive for PET but negative for MRD, actually we found that none of those patients have gone on to progress yet. And when we went back and looked at the converse, which was patients that were negative by PET for positive for MRD, a number of those patients have ultimately gone on to progress, suggesting that when these two tests are discordant, that ctDNA may be the more reliable of the two. So I think in the field of lymphoma, I think that circulating tumor DNA has a number of potential applications. I think one is use as a response assessment, probably in an adjunct at this point to PET-CT. I think that it can be used in the context of clinical trials, or it could be used sort of as a modified endpoint, i.e. after therapy as a patient. If a patient is ctDNA positive, in addition to being PET positive, there could be potential implications there. The hope is that in the future, circulating tumor DNA will be adopted into routine clinical practice, because I think it gives us a lot of information, as I just mentioned. In the times that PET and ctDNA are discordant, it can add additional information on top of what PET has and give us more clarity.